It's my pleasure to present for the ITI Academy online and to join this series of ITI Global webinar. My name is Teresa Chanting Sun, and I'm going to share with you some of the insight that on how to utilize autogenous gingival graft as a powerful tool for peri-implant soft tissue management. To briefly introduce myself, I finished my dental school in Taiwan and then further obtained a master's degree in and also American board certification at Tufts University in Boston. I was also an ITS scholar at the Harvard Implant Department and currently working as a specialist focused on the field of periodontology and implantology in Taiwan, McCain Memorial Hospital, and National Defense Medical Center. So today my topic is soft tissue management around dental implants. And we can see the trend that not only clinically, but also research interests are shifting towards to this direction for the soft tissue around the dental implant. So as a periodontist, of course, that I focus a lot on the pink aesthetic. And in recent years in my practice, that I can see more and more patients present to our clinic and with some of the soft tissue complications around the dental implants. As you can see from the screen, such as lack of keratinized gingiva, and soft tissue deficiency, loss of interdental papilla implant exposure, gingival recessions, and sometimes a malposition of the implants. And this kind of complication is even more challenging to handle when patients has an implant in the aesthetic zone and with a very high smile line. So this topic, the soft tissue related implant complication, has long been discussed, but in the literature, you can see nowadays there are more and more review articles and also research projects that were published and designed to address this specific issue. To discuss what are the factors that are associated with the soft tissue related complication around dental implant. So the ITI Treatment Guide, Volume 12, Peri-Implant Soft Tissue Integration and Management, published by Professor Roccuzzo and Professor Scullion. You can see in Chapter 5, there are one specific chart table. They were discussing what are the predisposing factors for the formation of soft tissue dehiscence around implants. And they listed some of the following, such as the facial osseous dehiscence, fenestration, buccally positioned implants, and also on the diameter of the implant, patient's gingival biotype or papilla height, keratinized tissue, frenum pool, and also on some of the patient's habit. So I think this is topic that are really comprehensive, and after a thorough search of the literatures, that I wanted to conclude that these factors, I think it can be divided into two main categories. One is the patient factor. So on the biotype, keratinized tissue, facial bone thickness, the facial crestal bone level, and also the bone deformity, the defect of the bony defect morphology, interproximal bone level, and also patient's behavior such as smoking habits, the healing potential, and also the maintenance program will play an important role. And moreover, while we are performing the implant treatment for our patients, I'll be trying to categorize this aspect into the clinical factor, and it can be divided into surgical or prosthetical. So I think especially the three-dimensional position of the implants for the surgical part, the position of the implants, the depths, the angulation, and how we selected a proper size for this implant is really, really critical. And if you are violating some of the key principle, it's really going to bring a negative outcome after the implant placement. And we also have to pay attention to the prosthetic design, which can also contribute to the soft tissue stability. So together with the patient and clinical factor, first, we wanted to identify what are the risk factors. We evaluate the patient's factor. And then to control the clinical factor through a thorough planning and also a very precise execution. I think these are the key for our treatment to be successful. So if we take a look at the patient factors, actually the soft tissue components plays a very important role, that the biotype, the keratinoid tissue, these are the factors that we can evaluate before the implant surgery. And I wanted to share with you that we wanted to know that is any surgical technique that we can utilize to modify this peri-implant soft tissue during the implant placement or after. And if there are some complications that already happened, can we treat this kind of defect like how we treat around the nature dentition? So before we jump into the surgery, that I wanted to start to share some of the basic concept with you. That we know the periodontal and peri-implant soft tissue share some of the structural similarity, but also some key differences. So the peri-implant phenotype can be divided into a soft tissue component and also a hard tissue component. A soft tissue component has three different parameters that we are usually measuring. One is the keratinized mucosal width, and the second is the mucosal thickness, and the third one is the supracrestal tissue height. And also the peri-implant bone thickness, the bone components plays a very important role for on the stability around the dental implants. The role of the soft tissue is quite similar for both dental implants and nature dentition. Dense soft tissue contact with either the tooth surface or the abutment can act as a barrier to protect and preserve the underlying bone structure. However, the connective tissues attached between the nature dentitions and also the surrounding bone appears to be different. Perpendicular collagen fibers, which is known as the Sharpie's fibers, connect the nature dentition to the cementum, but on the other hand, the collagen fibers runs in a parallel or circumferential manners around the dental implants, which can lead to a weaker connected interface around the dental implant. Therefore, that soft tissue sealing around the dental implants can be potentially more important to provide the peri-implant bone stability. So we know that, while patients have very thin biotype or genotype, it is more likely for the patient to develop recessions around nature dentition. And by a lot of different methods of periodontal plastic surgery, we can try to modify this genotype, this biotype, to a better phenotype, a thicker phenotype to prevent recession or to solve the recessions. So can we apply the same principle to the peri-implant soft tissue? So let's look back to some of the key surgical methods that has been developed over the years. So starting from, it's back into the 1960s that periodontists was trying to use different surgical technique and trying to gain the width of the keratinized gingiva. So it's so-called a vestibular or gingival extension procedure. So the flap is intentionally to be placed apically and then leave a space of the bone surfaces or periosteum to be exposed. And after the secondary intention healing, you can see there are increasing amount of keratinized mucosa formation after this entire surgical procedure. However, there's a great disadvantage of this surgical technique. As you can see on the diagram, the entire root surface of the surgical area are exposed. Therefore, it's usually not aesthetic pleasing. So further, there are other techniques that were developed, such as a pedicle graft procedure. So the concept is we can borrow the soft tissue, the structure that we need from the surrounding tissue, such as a lateral sliding flap that comes from a neighboring tooth, or borrowing from both directions, mesial and distally, it's so-called a double pupillar flap, or borrow tissue from apical towards the coronal portion, which is a coronally advanced flap. So we can see the aesthetic can be quite preserved and in this kind of surgical technique. However, there are still some limitations because sometimes the surrounding tissue might not have the enough amount of thickness and then the not amount of keratinized tissue that we need. So can we have more freedom that we can borrow tissue from an entire different origin, such as the palate or the tuberosity? So then the free soft tissue graft procedures, or by utilizing some soft tissue substitute, that we can try to augment the site with a lot of different flexibility. So these are the methods that are quite popular nowadays, and then it can also be applied to the soft tissue management around dental implants, depends on our needs. So this, in a recent published systematic review and meta-analysis by Dr. Tavelli and the Michigan group, a total of 52 articles were included in the qualitative analysis, and 23 randomized clinical trials were included as part of the network meta-analysis. So in their article, they are trying to focus the peri-implant soft tissue phenotype modification. And in general, the surgical approach can be divided into two main categories. The first one is a bilaminar approach, and the second is an apically positioned flap-based approach. The bilaminar approach is so-called a coronally advanced flap, and in conjunction with an autogenous graft, usually it's a connective tissue graft or some non-autogenous grafting material. Usually the graft is designed to be covered. And while we are performing an apically positioned flap approach, the graft is usually intentionally designed to be exposed, and it can be used with either autogenous graft, is usually a frictional graft, or some other material such as collagen matrix or a cellular dermal matrix. So you can see from their meta-analysis that in the group of bilaminar approach, the connective tissue graft group showing the greatest potential for mucosal thickness gain. And by thickening the mucosal thickness, the marginal bone stability was increased as well. But on the other hand, if you are trying to increase the width of keratinized mucosa, then probably an apically positioned flap together with a frictional graft is going to be the most promising methods. And the probing depth, plug index, and also soft tissue dehiscence on this kind of complication will decrease in the group. So you can see, depends on our needs and what's our goal, different kind of surgical approach can be selected. So I'm going to share with you two different cases that I utilize as two methods that mentioned in their publication. So first is the apically positioned flap together with a free gingival graft. So the frictional graft was described long ago back into the 1980s by Professor Bjorn. And it has been applied on the nature dentitions, and we can further apply the same operating principle towards to the soft tissue around the dental implants. So this 50-year-old female presented to our clinic with missing second premolar and 2 molars over the mandibular left sextant. So prior we are starting to do the implant therapy for this patient, we can see the patient has a reduced periodontians. Already she has some recessions around the nature dentition, and also the soft tissue quality that you can already see there's a lack of keratinized tissue to begin with. So after prosthetic design, that after the wax up, that we decided that we're going to go for a first molar occlusion for this patient. So 1 premolar together with 1 molar were planned for the patients, that we're going to place 2 implants and then to restore them separately. You can see the ridge is quite resorbed, so therefore the implants are planned to be quite close to the inferior alveolar nerve. So at the date of the surgery, the implant were placed uneventful and no additional bone graft was needed at the time of the placement. So primary stability of the implants were achieved, and then also the flap was primarily closed. And 3 months after the surgery, now this is the time that we were trying to evaluate for the second stage surgery, and this is a time that we see there's a need for some soft tissue management around this implant site. So you can see the lack of keratinized gingiva, the shift of the mucogingival junction, it's all extended towards to also the nature dentition as well. And if you look at from the occlusal view, that you can also see the lack of keratinized gingiva over the lingual side of this implant area. The remaining width of the keratinized gingiva is around 3 to 4 millimeters. So to us, the best approach is going to be an apically positioned flap together with the frictional graft to ensure that we can gain the width of the keratinized mucosa to the desired level. So I'm going to show you some of the surgical video that I took during the surgery from the operator's view, so you can have a very clear idea how you can perform the surgery. So first, the incision is made along the mucogingival junction. So this incision is quite shallow. Don't do it all the way to the bone surface, because consequently you're going to use the scalpel for a sharp dissection to create this recipient bed. So once you use on some sharp dissections to elevate the flap, then later on you can also utilize some of the blunt instrument and then try to push and extend it on this recipient side to more the apical area. And then the incision was made to a full thickness to locate the cover screw. And then the cover screws is then changed into the healing above. So the blades were used to try to ensure there are not no non-attached tissue, and to remove some of the excess of the soft tissue, which is not immobile. So once this recipient bed is fully prepared, then we can further harvest a piece of frictional graft to transplant this gingival tissues into the recipient area. So this is the time that we try to stabilize this frictional graft onto this recipient bed. So first, starting from some simple interrupted suture, it's important to put this graft at the desired position that you want. Then you see that the graft is quite stable at the position that you want. Then we utilize on some of the sling sutures. It's going to be a cross sling, and then it's anchored to the peristems around this graft. Then further, you need to examine this apically positioned flap, which is not interfering with this graft that you placed. So the healing of a regional graft can be divided into 3 different phases, starting from the stage of plasmic circulation that usually take place right after the surgery and then up to 2 days. And then this graft is going to be revascularized, and by about like 4 to 10 days, about 1 week, you are going to start to see some maturation of this graft. It's called the stage of organic union. So you can see this is the date of on the soft tissue on the regional graft procedure. And 2 weeks of the healing afterwards, 1 month. So by 2 months, I will start to utilize some of the provisional prostheses to try to do some soft tissue molding, and then later on at the very end to deliver the final prosthesis. So as you can see, that 2 screw retained zirconia prostheses were delivered. And when comparing to the pre-surgical condition, you can see we successfully achieved the goal that we are trying to achieve, which is the gain of the keratinized mucosa, the width. And you can see the bone level at the time of delivery, and then also at 1 year, it is very stable after the surgical procedure and then the final prosthesis. So you can see our purpose for this case is to try to gain the width of keratinized mucosa. However, there are some disadvantage of the regional graft. You can see the grafting area is a little bit more whitish, and there are some scar tissue which is not blending with the surrounding soft tissue very well. So for this kind of procedure, it's probably not ideal to provide and then to do a regional graft over a static zone. So therefore, I'm going to show you on this case that I utilize the concept of a bilaminar approach, and I utilize a tunnel technique together with a connective tissue graft and try to augment the mucosal thickness around a central incisor. So this 30-year-old patient presented to our clinic with the fractured left central incisors and also active infection. So the patient came in with a fractured along on this post. So this CBCT was taken before you can see the abscess, and later on we start to see the infections is getting more and more severe. So if you take a look at the CBCT, this facial bone is quite thin. And also consider that the patient has active infection. So our main goal is first to remove the infection and then later on provide a dental implant placement. So at this point that we decided it's going to be an early placement protocol. And the implant position is planned based on prosthetic-driven position after the wax up. So first we remove the tooth, and you can see the reach dimension start to change after the tooth extraction. So when compared to before and later on, you can see the resorption of both hard and soft tissue. So once the soft tissue is completely healed at 6 weeks, then we going to raise the flap and start to place the implant. You can see the buccal bone resorptions and a crater-like defect happened after 6 weeks of the extraction. And the fully static guide placement was planned, and the implant were placed, and the primary stability was achieved. So the contour augmentation followed by Professor Bruce's protocol was performed with first layer of the autogenous bone covered over the exposed implant surfaces, and then followed by a DBBM on xenograft. Then on 2 layers of the collagen membrane were applied to protect the grafted area, and primary closure with a flap was achieved. The healing was uneventful. So 3 months after procedure, that this is the time that we are trying to evaluate for the re-entry for the second stage surgery. And if you take a look from the occlusal view, that we can still see some soft tissue deficiency that when comparing to the neighboring nature dentition. So this is a time that we are thinking that if we are trying to achieve a very pleasing aesthetic outcome, probably we wanted to utilize the connective tissue graft and try to increase the mucosal thickness. So the bilaminar technique, which is so-called the chronally advanced flap, can be performed in various of different ways with different surgical technique. So the conventional technique usually comprised with 2 vertical incision and an entire flap was raised and tried to chronally advance. But nowadays that people are trying to limit it on the incision that's needed. So therefore the envelope technique was developed. And also with micro instruments, some specific instrument, the tunnel technique, or either the visa technique that have very minimum amount of incisions can be made, and then this connective tissue graft procedure can be performed. So in our cases that I utilize the technique, which is so-called the tunnel technique. So first, the microblades were used and to make incisions on top of the cover screw area, and then also at the adjacent tooth intraocularly. And then a series of the tunneling instrument with different size, angulations, and then different shape were inserted into this incision and try to create a supraperiosteal pouch from a different direction. So you have to be very gentle and trying to connect this pouch from different directions, and then to release the tension of this pouch by utilizing a series of different instruments. So once this pouch is successfully elevated and you can feel like this entire area has a very tension-free elevations, then we can start to harvest a graft from the patient's palate or from the tuberosity, like our case here. So a tuberosity connective tissue graft was harvested. I harvested as a full layer, and then later on the epithelialized epithelial layer outside the patient's mouth. And then we try to stabilize and insert this graft into the surgical site. So it goes from the incision that we made crestally, and we utilize the suture from the mesial and distal of this graft to try to pull this graft into the pouch that we created. So the suture goes from the buccal side of the flap and then penetrated towards to the incision, the crestal incision, and then grab the flap, grab the graft at the mesial side and also from the distal side, and then pull it into the buccal side of this implant area. And 2 nuts were tightened to stabilize the graft. The cover screw were then connected into the healing abutment. And 2 to 3 months after the surgery, we can start to make a provisional prosthesis, try to manipulate and then shape the soft tissues around the dental implants, and then to a desired aesthetic level. And the final prosthesis was then delivered. The patient is very happy with the outcome, and you can see while we are comparing the pre-surgical CT and then also the 1-year follow-up, since we are doing a fully guided placement, so the implant position is quite satisfactory. And also by doing the bone augmentation, the crestal bone stability is achieved. So after showing 2 different cases that I utilized different surgical technique to augment the soft tissue around the dental implants, now the questions comes to, if the implant is already placed and then the complication already happened, can we treat this kind of complication, the soft tissue related dehiscence, around the dental implants, like how we treat them around the nature dentition? So while we're talking about the treatment of soft tissue related complication around dental implants, the first thing is we actually has to know what is the limitation of the treatment. So the most important part is the prosthetic consideration, and then it goes from the depth of the implant and also the angulation. So we know implants should be placed at least 3 meters from the future desired crown margin. And the headache implant is actually when you are placing the implant too shallow at the aesthetic zone, then it's very difficult to compensate from a prosthetic point of view. And sometimes this kind of implants might need to be explanted. And also the angulation, you need to control it very well. So if you see the point of the emergence is located at the apical third of this crown or even beyond that level, usually that indicates that this implant is placed too far buccally in most of the clinical scenario that you might consider to remove the implant. So, for example, this is one of the clinical cases that come into my clinic. The patient is very unsatisfied with this implant placed on the lateral central incisor. So you can see the implant is placed, first is very deep and then very buccally angulated. The pink porcelain doesn't help with the aesthetic, and then there's no other way but explant this implant. There's no way that we can rescue it and still achieving a pleasant aesthetic outcome. So once we know the limitations and then decide whether we are going to save the implant or we're going to treat it, then a proper treatment protocol can be selected. Based on these publications by Professor Zucchelli and his group back in 2019 on the classification of facial peri-implant soft tissue dehiscence and deficiency. So he classified this kind of complication into 4 different classes. The class 1 and 2 indicates that the implant crown is actually pretty ideal. It's not too bulky, and with different various of degree of the recession. So when it comes to class 3 and 4, usually the crown of this implant is too bulky. And this is a time that you'll need to remove this crown of the implants and then evaluate from the entry point of the implant to see either the implant is located and placed too buccally and it's going to be going beyond the lines when you connect on 2 adjacent tooths, then it's going to be a class 4. Then depends on the integrity of the interdental papilla that it can be divided into 3 different subclasses, A, B, or C. So you can see if it's class 1 or 2 and without any compromise of the interdental papilla, then sometimes pure surgical approach to try to solve the recession is possible. However, if it's class 3 or 4, or even if have an extensive amount of loss of interdental papilla, then probably you'll need to consider to remove the prosthesis, and a combination of prosthetic and surgical approach will be recommended. And in some extreme situations, implant removal is also recommended in their publication. So let's take a look at my patient. She's 33-year old, about to get married, and she's very not happy with the smile. You know that during the wedding, there's a lot of pictures to take. So she comes into our clinic to see if there's any way that can solve her problem. So you can see the recessions around the dental implants over on the right lateral incisors, and also the crown shape and on the level of the soft tissue is not ideal at the 2 central incisors as well. So we decided we're going to plan to replace all of the crown over this maxillary anterior sextant and try to solve the peri-implant soft tissue complication for her over this left central incisor. So we further take a look and do some examinations for this patient. So while you are evaluating from the occlusal view, you can see first the crown is quite bulky when comparing to the neighboring tooth. And also after taking a CBCT, you can see this implant is very buccally inclined, and it's almost no buccal plate around this dental implant. So give us an insight that probably this implant is placing too buccally angulated. And so we remove the implant crown and evaluate from the implant level. So you can see this head of implant is also go beyond to the line when you draw from the adjacent 2 teeth. So we classify this on clinical cases as a class 4A. So luckily, the interdental papilla is intact. So we decided to go for a combined prosthetic and surgical approach for this patient. So the first thing we do is we further remove this bulky abutment and then let the soft tissue to heal and change it into a thinner, polished healing abutment. So you can start to see on the level of the soft tissue, it's actually start to creep in. And then once there's no inflammation of the soft tissue, then we can further plan for the surgical approach around this dental implant. So a chronally advanced flap with 2 vertical incisions was then made at the date of the surgery to ensure this entire flap can be chronally advanced to the level that we want. So starting from the partial thickness dissection to create the ideal shape of the surgical papilla. And then later on, once it reached to the crestal bone, then we start to use some elevator to elevate the flap full thickness. And when it goes more towards to the apical, you can start to see on the implant is showing through some of the metal color. So this is a time that we start to use some sharp dissection for partial thickness elevation, try to preserve some of the connective tissue around the dental implants. And later on at the very apical portion that we utilize on the sharp dissection, trying to do a tension releasing around this flap, and try to chronally advance this entire flap without any tension. Try to have it very passively. And the chronal gingiva was then deepithelialized, and this is going to be the anchor for your surgical papilla. So you can see, as we see from the CBCT, actually, this is probably some very limited amount of facial bone around this implant. So once we prepare this recipient side, then we are going to go for the harvesting of the connective tissue graft from the patient's palate. So if we look into detail of some histological slides, that you can see the connective tissue has different layers. And then when it goes to deeper layer, which is closer to the bone surface, there are more glandular or fatty tissue, which will be more, the quality is not good. And if you have this connective tissue graft is mainly composed by the glandular or fatty tissue, then this might result on some of the greater dimensional change of the tissue. So therefore, by performing different technique of harvesting of the connective tissue, we can actually harvest the connective tissue from different layer, the different positions from the patient's palate, or sometimes we can utilize a tuberosity CTG. So in our case, we utilize this technique, which is so-called the deepithelialized connective tissue graft. So we first harvest the entire regional graft. Then we deepithelialize outside the patient's mouth. So this gives you a lot of control when you are trying to control the thickness of the flap, and also when you are trying to obtain the connective tissue from the most superficial layer of from the patient's palate. So this entire graft is very unified, and then the thickness is the desired thickness that we want. Then we secure it over the decision, the recession defect. Then the buccal flap was then crawley advanced, and then secure it over the grafting material to cover, and then crawley advance over the healing abutment. So you can see the healing at 2 weeks follow-up, and it's quite uneventful. And by the time of the 2 months, the tissue start to mature. Then we change it into a set of provisional prostheses. Then after several months of modification, the final prosthesis was then delivered. So you can see this is how it looks like when she come in at the initial visit with the recession around the dental implant. And then this is how it looks like after the treatment and also 3 years follow-up. So I believe the principle for treating the soft tissue complication around the dental implants can be quite similar like how we evaluated around the nature dentition. The first thing is we need to identify the etiology. And by selecting the proper treatment protocol, either it's a prosthetic or surgical or a combination approach, then by utilizing a good quality soft tissue graft and then to position and stabilize it at the right positions, and afterwards, after the surgery, we emphasize what's the importance of the maintenance to the patient. This kind of treatment can be also applied to treating the complications around dental implant. So this were the slide that I showed you at the beginning of this presentation, that we know that by the periodontal plastic surgery, we can modify the patient's biotype or genotype to a phenotype which can be more likely to prevent the recession or complication from happening. And I believe the same principle can be applied on peri-implant soft tissue, that we can utilize the autogenous screen jaw graft and try to modify the phenotype and then provide this patient with a more stable environment, and then for the complication to happen less likely. So I think this entire concept is actually the concept of prevention. And we evaluate the patient based on the SAC tool. Before the surgery, we take a look at the soft tissue, and if we see there are some deficiency and also the patient's biotype is a risk, then we can utilize different surgical approach, try to modify the peri-implant soft tissue before or after we deliver the final implant prosthesis. So basically that we try to provide the tissue stability, and with the emphasis of the peri-implant maintenance, I believe it's going to be on the key factor for the successful implant therapy. So by the end of the day, I really don't want to see this kind of soft tissue complication that happens in my patients. So I hope on today's presentations will give you on some content that you like. And thank you so much for listening to this webinar. And I'm looking forward to interact with you in the Q&A section. Thank you. Okay, so thank you so much for joining this webinar series. So I'm here to answer all of the questions. I hope you enjoy the content. So let's start from the first one. The question is, what evidence is there to show that circular fibers around the implants are actually weaker than the radial fibers around the tooth? So this is a very interesting question, and thank you for bringing this up. And I think when I talk about the structural differences that I show the diagram inside my presentation, most of the time that we refer this back to Dr. Berglund back in 1991, talk about the soft tissue seal, soft tissue cuff. But we know that it's under histological observation study. And so most of the study, as far as I know, are all animal studies and then histological. So it's probably difficult to design a study and directly compare in a clinical environment, saying that how difference is in terms of the attachment ability. However, we can see from a series of animal studies, say published later on afterwards by Berglund, Lindy, that in animal studies, that if the animals has good seal, has good keratinized tissue around the implants, compared to if the implants are placed only inside mucosa and then without any proper hygiene, then there are more tissue destructions around the group which are placed inside the mucosa. So I think there are indirect evidence and to support this concept, and then I guess more and more evidence will come in the clinical setting, and then showing that probably soft tissue seal can help us in terms of preventions, or it's going to be helpful for certain site-specific or patient-specific situation. So this will be my answer to the first question. And the second question is, what type of sutures do I prefer to use? So most of the suture that I show inside the lecture is either a nylon or a polypropylene. The reason being, I prefer to have I prefer to have monofilament suture, which is less plug retentive when you are preferring mucogingival surgery. And so the next one is, how stable is the modified genotype over time? Let's say 5 to 10 years stability. So I think the concept of using periodontal plastic surgery to modify the genotype around nature dentition is quite well documented in terms of either 5 to 10 years on longitudinal studies. Around dental implants, probably still not so much evidence available in terms of such long period follow-up. But I see more and more evidence coming in. So I guess I'll probably suggest all of us to be focused and then see what are the available evidence in the future. And so later on, so the questions, another one is in the clinical photo that I have is a connected tissue graft from the first molar area, including the distal part. In many textbooks, they recommended more mesial area. Do you recommend it more distal area? So I'm not pretty sure about which case are you referring to in terms of the harvesting. But of course, I think in my presentation, I show a different harvesting technique. And if I'm harvesting a graft from the palate, and then if it's a deepithelialized connective tissue graft, which is I harvest FGG first and then deepithelialize, sometimes the depth doesn't really go very deep. So in that situation, I'll probably not worry so much. But of course, if you are using conventional one incision harvesting technique, I'll definitely recommend you to go on from the first premolar to on second premolar, not reaching to the distal of the first molar area, because both on the evidence suggests that not only you are staying away from some vital structure in terms of the greater palatal nerve and then artery, but also the connective tissue thickness has the greatest dimension in that area. So how to use tissue level or bone level implants in posterior side. So I do have a series of different implant placement and then different implant selection in terms of the posterior area. But I do see both the evidence and then also clinical observation shows that a tissue level is probably more biological favor in posterior area if you don't have any aesthetic concern. And I find tissue level sometimes in terms of the perspective of soft tissue management might be facing some limitation, which is we tend to expose tissue level implants at the date of the implant placement. And we know that if we're trying to do a regional graft, this kind of procedure, most of the time we do it at the time of the second stage. But nowadays, if I place tissue level implants, I'll probably just use it with the apically positioned flap. So if patient require a graft, then later on they'll need additional surgery, which is probably going to be you'll need to discuss with the patient in advance. So that will be my take-home point. And what are the use of so bulking up the soft tissue around the dental implants, I would say I don't have this experience that much. Because nowadays I find soft tissue substitute, I'm still trying to experiment like how stable would it be, and I think it's still at the stage that everybody is trying to experiment and also trying to see if any soft tissue substitute can help. So I guess we'll wanted to see more and more evidence coming in terms of using other materials than autogenous graft. And how do I select or consider to use Vista approach or tunneling technique? So on the Vista approach, I think it's referring to Professor Zadak, and then usually one incision is made vertically at the central and at the center of the vestibule. And then a series of instrument is going to go on underneath and create the pouch from lateral side. And a tunnel technique, usually intraocular incision was made, and then the instrument can go in from intraocular direction. So on the visa approach, I think it will give you some limitation in terms of the distance between where you made the incision and where you're going to reach to. And on the tunnel technique, I find it to be a little bit have a little bit freedom, which is more closer to my surgical area. But I think both technique can work very well, and then both of their concept is trying to minimize the use of the incision, especially a vertical releasing incision and aesthetic zone. Sometimes it will create some scar tissue. So I think if you want to try, you can try both and see which approach will you prefer. So how do I avoid mental nerve disturbing during split thickness flap preparation? So this is really a good question. So I think one of the main disadvantage of doing a fusion graft on the mandibular area, especially when it's very close to the premolar area, will be definitely the risk of damaging the mental foramen area. So I'll suggest when you're trying to perform this kind of procedure, first you really need to locate where is your mental nerve and then do some proper measurement. So if it's really close to the area, then when you are doing apically positioned incision, then you'll probably need to limit the depths that you go, don't go all the way in, and then because sharp dissection will probably gives you the possibility of compromising the integrity of the mental nerve. And if so, but you still wanted to perform the procedure, I'll probably suggest you to use blunt instrumentation when it reach to more apical area. And so in the bilaminar case in which a tunnel was prepare involving 1,3 and 1,1, why do the adjacent teeth need to be involved? I don't quite understand which case is this referring to. I think if you're referring to the case which I present at the last one for the implant coverage, no, the 1,3 and 1,1 were these two teeth were not involved in the surgical preparation. So the two vertical releasing incision was made at the mesial and distal side of the implant side, and then I did epithelialize the papilla around the implant, and tooth 1,1 and 1,3 were not touched. So the next one will be in the thickness of connective tissue graft, critical for treating soft tissue deficiency. Okay, so the thickness of connective tissue graft, so is it thicker the better? So I think nowadays, after performing many soft tissue grafts, nowadays I prefer to value or emphasis on the quality of the graft instead of the thickness. So if I'm taking a graft which from the superficial layer of the palate or from a tuberosity, then I'll probably try to avoid using a very thick graft, because some of the literature does indicate that if you have graft coming from tuberosity, sometimes there will be overgrowth of the graft at the later stage. But if you are trying to achieve, for example, edentulous area, and then you try to bulk the volume a lot at the pontic area, probably you might want to have a thicker graft to achieve what you are hoping for. So from my clinical experience, do I feel this kind of soft tissue modification prevent future peri-implant diseases? I think there are more and more studies on some of the randomized clinical trial, which one of them published recently by Alberto Mongi, and then also Dr. Blasi, showing that if patient is not complier, then the importance of the presence of carinized gingiva and also the amount of carinized gingiva is more important when they compare to if patient perform very good plaque control with good maintenance program. So I think it's really based on the patient's profile. And then if we take a look from a preventive point of view, because you never expect that if patient going to show up or come back to your practice after you place this implant, then from my point of view, I think it's going to be helpful for preventing some of the future diseases. That's how I believe it. And I would like to know what is the take on using CTG to augment the peri-implant soft tissue when previous GBR failed to regenerate the most coronal bone next to the implants. Okay, thank you for this question. So this is a very interesting question because we know that if you have a GBR before and later on the GBR failed to achieve your expectation, so which means that you feel like the dimension of the tissue is still not favorable for on what you are hoping for. I think in this kind of scenario, by performing a soft tissue graft and then using thicker tissue to compensate the dimension that you need is probably feasible. And then also, I believe if that's a situation, even if it's in aesthetic zone and then the dimension is not favorable to achieve a total very aesthetic result, if you still need to use pink porcelain, this kind of device, but if you have good amount of carinized gingiva and patient can perform good plaque control, it's going to help for a previous failed site. And on how thick is the connective tissue graft used to correct on the buccal contour in the class 4 recessions on the implant? For the final crown, would a porcelain-fused metal crown works, or it is better to use a zirconia crown with non-glazed cervical? Okay, so this is 2 different questions. So the first question is on how thick would the graft be? So if I have the graft, which is, I think it's good quality and good consistency, then probably a graft around 0.8 to 1.2 millimeters is thick enough to cover the recessions. And for the final crown, I think the reason that if we prefer to use all ceramic restoration, I think the concept will be because we know that these evidence, for example, treating recessions around dental implants with soft tissue grafts are only available within this couple of years. So we're still in the stage that we're trying to observe for a long-term period of time. Is it going to be further recessions or is going to be stable? So I think for the aesthetic concern, probably it will be a good idea to deliver a porcelain fused metal crown and then also with the zirconia abutment will be a little bit more safer to in terms of the preventive point of view. Comparing traditional free gingival graft and strip gingival graft, which result is better in terms of tissue height stability. So a conventional free gingival graft and then the strip gingival graft, in my experience, if you are trying to achieve the increasing the height of the supracrestal tissue height, then a conventional free gingival graft is going to have less dimensional change because in a strip gingival graft procedure, the soft tissue substitute is more closer to the implant on site, and then the strip free gingival graft is using it at the more apical direction. So the soft tissue substitute usually experience more dimensional change. So if you're looking for a stability, I think of conventional regional graft will be better. However, the reason that we are trying to use a strip gingival graft, the main concern is usually if you are using it in aesthetic zone, and a regional graft in direct contact to the implant, next to the implant, will probably result in some color mismatch and also some texture, which is not very aesthetic pleasing. So therefore, the gingival graft is only harvesting as a very small strip and then place it at the more apical area, and then using another soft tissue substitute to cover the area which is parallel stems or exposed bone surface. And what is my view on the use of PRF in such cases? I think I will say probably I don't have really a lot of experience in PRF, and also I don't see a lot of evidence suggesting by adding the PRF there will be increasing in soft tissue thickness. But I see a potential for it to be utilized as during the healing period. Probably it's going to facilitate healing that can be used in such case. And when would I consider augmenting the soft tissue before hard tissue management or implant placement surgery? So I personally don't do this approach a lot. I know a lot of people will be really worrying about if you don't have enough of carinized gingiva, then at the time of the GBR, then you won't be able to close the site. I guess I'll probably consider when the tissue is very, very thin. And in terms of the width of a carinized gingiva, as long as I have small band, I'm comfortable with it. So I'll be more concerning if the soft tissue thickness is not enough comparing to if I don't have enough carinized gingiva in terms of GBR, soft tissue augmentation before GBR. And in case of gingival recession with tissue level implants, is there any modification to the recession correction protocol, or explantation is inevitable if the polish color is exposed in the aesthetic zone? Oh, the tissue level implants. So I think if it's a tissue level implants, because you cannot remove a bone level implants, you can change it to the abutment configurations, but a tissue level implants, you'll probably be facing on a different scenario. I guess if it's me in a clinical setting to evaluate a tissue level implant in terms of the possibility of covering this implants with soft tissue graft, then I'll probably try to evaluate the angulations and position of the implants. I think that this will be the most critical points. If you follow the guideline, it's more kind of like it's not too buccally placement and then the papilla is sound. I think there might be some possibility that you can still utilize a soft tissue graft to cover the exposed surface. And when FGG technique was utilized, it might cause colored mismatch. How do you prevent this color mismatch? I don't think there's a good way to prevent the mismatch. The reason being, I have performed a lot, and sometimes during 1 month or even 2 months of healing, you feel like in the initial phase, it looks quite pretty. However, if you wait until like 1 or 2 years, you can start to see the differences. I guess that's why some of the people, they're trying to use actually a free connective tissue graft. I think that might be an interesting approach to see if there will be some positive change in terms of the aesthetic. So therefore, that's why that I suggest don't use this technique in the aesthetic zone. So will Dr. Sun provide ways to prevent occurrence of peri-implant tissue problem? I guess this is what this lecture is about. Like, as a periodontist, I think soft tissue management is one of the way that I can do for my patient, and I do believe this will um, bring a significant difference in terms of prevention of peri-implant disease. So, and oh, there's Dr. Roccuzzo. Thank you. Okay, so I think I pretty much answer all of the questions. Um, okay. So, thank you so much for joining this webinar series. And I do include both my Instagram, Facebook account, and also my private email in the last slide. So if you feel like you have more questions to ask me, you feel free to send me a message or to contact me in the near future. Thank you so much.